Hi, my name is Ellen, and I conducted my research on Merle Michel's uncertainty in illness theory. This is one of the middle range nursing theories. Merle Michel first published this theory in 1988 following personal observations of her father's experience with cancer and how uncertain of an illness that was. She defines uncertainty as the inability to structure meaning of illness-related events, inclusive of inability to assign definite value and or to accurately predict outcomes. Since this theory was published in 1988, which was over 35 years ago, researchers have used it in numerous nursing studies, and it continues to guide research and nursing practice in present times. It's appeared in both qualitative and quantitative designs and in a variety of patient populations and settings, such as inpatient and outpatient settings amongst nurses caring for patients and amongst caregivers and surrogates of patients. Overall, there is an extremely vast body of literature using this theory, and it can guide the development of nursing interventions, which can in turn influence cognitive processes and ultimately address uncertainty. There are a few important assumptions to understand about Michel's theory. Patients experience uncertainty when they lack knowledge about a new diagnosis and when they have lower cognitive ability to process their illness. They also experience uncertainty when they have fewer resources and support systems and when they use ineffective coping strategies. However, patients can lower their uncertainty and achieve the end goal of adaptation when they are more informed about their illness and when they have greater cognitive ability to process it. Patients can also lower uncertainty when they have access to resources and support systems and when they use effective coping strategies. All of these assumptions are explicit because they are concrete and testable in research. I would say that epistemology is the branch of philosophy that guides Michel's uncertainty in illness theory. This is one of the philosophical schools of thought, and it is defined as the study of knowledge, which includes ways of knowing, nature of truth, and relationships between knowledge and belief. Michel's theory is so focused on knowledge. Those who have greater knowledge and stronger ability to cognitively process their illness can better cope with stress, and overall, this leads to a better adjustment to uncertainty. There are 4 concepts central to Michel's uncertainty in illness theory. These are antecedents generating uncertainty, appraisal of uncertainty, coping with uncertainty, and adaptation to illness. The following slides will focus on each of these concepts. The first concept, antecedents generating uncertainty, contains 3 components: stimuli frame, cognitive capacity, and structure providers. Stimuli frame refers to any stimuli that can lead to uncertainty when patients are not familiar with an experience. Examples would be unfamiliar symptoms, a new healthcare environment, or a new treatment. Cognitive capacity influences how a patient would form a cognitive structure to interpret particular stimuli. If a patient has stronger cognitive capacity, they can better understand stimuli, which ultimately reduces uncertainty. And then the structure providers are credible authorities who can provide education on an illness, such as a doctor or a nurse or any other healthcare provider, or who can provide resources to cope with illness, such as social support systems. If patients have the appropriate education and support, they can more accurately predict and understand their experience, which ultimately results in lower uncertainty. The second concept is appraisal of uncertainty. This is a cognitive process used to determine whether a stressor is a danger or threat, or an opportunity or challenge. If the stressor is viewed as a danger, which could potentially result in a negative outcome, patients will attempt to use various coping strategies to lower uncertainty. For example, they may try to seek out information and take any step within their power to get better. However, if patients see uncertainty as an opportunity which could possibly result in a positive outcome, then they will use coping strategies to maintain that uncertainty. An example is if a patient has uncertainty about the prognosis of their illness, and they choose to see that uncertainty as an opportunity with the positive outcome of potentially surviving, then they can adopt positive feelings such as hope, faith, perseverance, etc. And these positive feelings maintain uncertainty because they ultimately preserve the ambiguity of the situation. The third concept is coping with uncertainty, which is the result of one's appraisal process. Coping refers to the mental and physical effort used to manage the stressor of uncertainty. When uncertainty is appraised as a danger, patients will use various coping strategies to eliminate the source of uncertainty, such as gathering medical information, taking any direct action in an attempt to control the situation, or seeking emotional support to minimize the stress. These are examples of mobilization strategies and affect control strategies. But when uncertainty is appraised as an opportunity, patients may use buffering strategies, such as avoidance, selective ignoring, or neutralization of threatening information. These are called buffering strategies because they maintain uncertainty by ultimately blocking input from stimuli. Adaptation to illness is the final concept, and this is the end goal. It is characterized as achieving new balance and adjusting to the new illness-related experience. When patients reach the state of adaptation, they form a new life perspective, which is a new lifestyle following the acceptance of uncertainty as a natural rhythm of life. Michelle argues that individuals best adapt to uncertainty of illness when they use effective coping strategies. These are some relational statements between uncertainty and the four central concepts. So uncertainty increases when patients are unfamiliar with the stimuli frame, lack cognitive capacity, and don't have support from structure providers. Uncertainty is also maintained when patients appraise it as an opportunity and use buffering strategies to cope. However, uncertainty decreases when patients become more familiar with the stimuli, acquire stronger cognitive capacity, and gather education and support from credible sources. And when patients appraise uncertainty as a danger, they use various coping strategies to lower that ambiguity. Reducing uncertainty ultimately helps patients adapt to their illness. For my research, I used the UMass Amherst Library's online search engine. My key terms were uncertainty and illness theory and Michelle. My search criteria were academic journals written in English published between 2000 and 2024. This search yielded 274 sources, and I chose 5 to ultimately inform my critique. The selected studies were published within the last 10 years so that the research results would be most current to present times and applicable to current nursing practice. I also chose articles with a variety of research design methods to show that different types of research studies can yield results that respond to the same research topic, uncertainty in illness. And lastly, I selected studies that were used in a variety of settings and populations to give merit to the theory's application in a wide variety of scenarios. I would say that Michelle's theory is logically adequate. It is very reasonable that having knowledge from the stimuli frame, efficient cognitive capacity, and access to structure providers would help with processing illness and lowering uncertainty. It is also rational that appraising uncertainty as a danger and using those mobilization and affect control coping strategies would help achieve more clarity in the end goal of adaptation. One omission from Michel's theory is that it doesn't address what would happen if one only acquired some of the criteria necessary toward adaptation. For example, suppose a patient were to lack access to medical information and resources about their illness, but they did have effective emotional support systems and strong coping skills. How would this impact their overall level of uncertainty and ability to adapt to illness? Michel does not touch on this in any of the research that I read about. However, this theory does meet the test of parsimony. It's comprehensible and it is not abstract. It is applicable to a wide range of healthcare settings, patient populations, and medical situations. Although Michel's theory can be summarized succinctly and only has 4 main concepts, it still has a lot of depth, and it is certainly not a simplistic idea. Michel's theory also has operational adequacy because researchers have been able to measure the concepts from the theory in various studies. I'm going to now talk about 2 studies that I read about extensively in the literature and ultimately used to inform my critique. We have Ozkan and Arslan's 2022 study and Hyson et al.'s 2024 study. Ozkan and Arslan in 2022 conducted a randomized control experimental design to investigate the effects of nursing interventions on the uncertainty and hopelessness of caregivers of children who were diagnosed with cancer. This was a Turkish study, and it targeted caregivers over age 18 of children receiving care at pediatric oncology inpatient and outpatient facilities. The researchers used the parents' perception of uncertainty and illness scale to measure uncertainty perceived by the caregivers, and the Beck hopelessness scale to assess negative expectations of the caregivers for their child's future. Because this was a randomized control design, there was both an intervention group and a control group. The intervention group received both counseling on uncertainty and education on symptom management, whereas the control group only received the education. After the counseling and education, the intervention group had lower uncertainty scores on the perception of uncertainty and illness scale, and they also had lower hopelessness scores on the Beck scale. Hyson's study from 2024 was a path analysis study on patients with coronary artery disease at Busan National University Hospital in Korea. The researchers used a model intended to predict health behavior according to how one appraised uncertainty. They used the Korean version of Michel's uncertainty and illness scale and uncertainty appraisal scale. They also used the RAND medical outcomes study, which measures social support, and the patient-reported outcomes measurement information system, which measures self-efficacy. They also used the attitudes and beliefs about cardiovascular disease risk questionnaire to measure perception of risk and intention to change behavior. The researchers found that when uncertainty was appraised as an opportunity, self-efficacy, social support, and perceived benefit and intention were all significant in attaining health behavior. And when uncertainty was appraised as a danger, perceived benefit and intention significantly affected the attainment of health behavior. In both cases, participants had developed a new perspective on life in which uncertainty was accepted as a natural part of life, so they did reach that end goal of adaptation. From these 2 studies, I can say that the concepts from Michel's theory are operationally defined because here in these 2 studies, they are applied to real-life scenarios and they are assigned meaning in real-world situations. I would say that there is a mostly reasonable match between the operational and theoretical definitions of the concepts. In Michelle's theory, she proposes that education and support can reduce uncertainty, and that is consistent with the results from Ozkan and Arslan's study. In Heisen's study, appraisal of uncertainty as both an opportunity and a danger positively impacted health behavior and helped patients accept uncertainty as a natural part of life. These results are mostly consistent with the theoretical definitions from the theory, but in this situation, appraisal of uncertainty as an opportunity actually results in adaptation and not the maintenance of uncertainty, which is what Michelle argues and what is one of the central concepts of the theory. Michelle's theory, I would say, does have pragmatic adequacy because it is highly applicable to the real world of nursing practice. I'm going to now talk about 3 more studies from the literature. These were the other 3 studies that I used to inform my critique. We have Kim et al.'s study from 2023, Turgut et al.'s 2022 study, and Cyprus's study from 2016. Kim et al.'s study was an integrative review which described domains of surrogates uncertainty and uncertainty processing in the context of end-of-life care planning for people with dementia. It was found that caregivers who lacked support from significant others, education on the symptoms of dementia, and time to access care services faced greater uncertainty. Kim et al. Recommends that healthcare workers should provide surrogates with information on advanced care planning to address uncertainty. However, it may be helpful for nurses to have further education and special skill training before applying this recommendation in practice. For example, there is a training program called End-of-Life Nursing Education Consortium, Geriatrics and Respecting Choices, and this might be helpful for nurses to take to improve their competence with advising caregivers on advanced care planning. Turgut et al.'s study from 2022 was an interpretive descriptive study via interviews with ER and ICU nurses to learn how uncertainty regarding COVID impacts their professional, personal, and social lives. This research is highly applicable to the real world of nursing practice because these were frontline workers, but also COVID impacted all healthcare providers on a daily basis at the time of the study. From the interviews, the researchers found that nurses can focus on providing thorough patient care to reduce uncertainty and stress on the job, and they can also focus on positive feedback that they receive from patients and families, and on the growing awareness in the news of how vital their professional contributions are, and use this as a means of inspiration and motivation to continue working during the pandemic. It's definitely feasible to implement these recommendations in real-life practice, but nurses may need incentives, such as financial and moral support from their institutions in order for that to be realistic. Cyprus's study from 2016 was a phenomenological study via interviews with nurses to explore uncertainty among both patients and family members during critical illness. It was found that nurses are credible authority and they can help patients manage uncertainty by providing information about what is happening during the ICU stay. They can assist them in appraising uncertainty, and they can help them develop meaning from their critical illness experience. For example, nurses can teach patients about signs and symptoms, what to expect going forward. They can provide encouragement and realistic reassurance, and they can offer social support or make a referral to a support system. It is definitely realistic and feasible to implement these suggestions in real-life practice, but nurses may benefit from additional education or staff development sessions on how to address uncertainty. Overall, despite a few areas where nurses could use more education and support from their institutions and their workplaces, The theory-based interventions suggested by all of these research results from all of these articles are very consistent with current expectations for nursing practice. In today's age, medicine is becoming so complex. It seems as though patients of all ages have multiple chronic conditions. There is the emergence of new antibiotic-resistant superbugs and pandemics like COVID-19. Overall, with greater complexity comes greater uncertainty. I think that the uncertainty in illness theory will likely contribute to the science of nursing for many years to come by guiding interventions that allow for greater clarity and acceptance in these difficult, ambiguous, uncertain situations. Although researchers have studied this theory in other countries, it does not specifically address culture. The nursing interventions proposed are general and they are not targeted towards specific cultural groups. So this theory would not help nurses practice in culturally competent ways. The impact on culture is definitely an area for further growth. Also, research on whether patients can lower uncertainty by acquiring only some of Michel's criteria would be beneficial to know more about before implementing this theory in nursing practice. Here is a list of my references. Thank you so much for your attention to my presentation.